Hi everyone, and welcome to today's Fertility Circle event. Thank you for joining. We are recording today's session, so just keep that in mind if you're asking any questions, and it will be available for playback via the Fertility Circle app. For anyone not already signed up or aware, Fertility Circle is a new app and community and go-to fertility companion for anyone trying to conceive, whatever the path to parenthood. And you can find us in the app stores by searching Fertility Circle. My name is Jo. I am COO of the Fertility Circle, and we're joined today by Julie Morgan. Julie is an independent fertility nurse consultant, and with more than 27 years clinical experience, she runs All About Infertility to support patients going through IVF treatment. And she's going to speak to us today on IVF planning. If you have any questions as we go or at the end, please do feel free to use the chat box. I will be moderating that and can pose your questions to Julie, or if you prefer, feel free, there will be time at the end to unmute and ask your questions. So without any further ado, over to Julie. Thank you.
Hi, let me just share my screen if I may. There we go. Can everyone see?
Yeah, that's great.
Great. Okay. So, welcome. I'm Julie. I'm all about infertility. I have been nursing for almost 35 years, the majority of which in an IVF clinical management setting. I've had a very privileged career. I was in the first ICSI team, the first egg freezing team, the first Saviour siblings, and I've personally reviewed at least 20,000 IVF cycles. And one of the main things that I've learned is that IVF is all about attention to detail and all about incremental gains. 2% here, 5% there, it all adds up. And one of the things that I think is very, very important is to prepare, so that there are two sides to the preparation. There's the things that the patient can do to get themselves and their body ready mentally and physically. And then there's the side of things that the clinic can do. And I think that's equally important, and it's not something that we talk about very much, but clinics have a responsibility to make sure that they prepare properly for a cycle, to make sure that they've got all the information that helps them get the maximum out of the cycle for the patient. So what we're going to do is I'm going to start first and foremost with the patient side of things. We'll go 10 tips. My first tip is planning. Sounds like as if it's a normal thing, but I think unless someone's had an IVF cycle, they really don't get or understand completely that an IVF cycle is like a full-time job. It's exhausting, it's stressful, it's always more expensive, always more. You just need more of everything than I think anyone realizes. So I would always say, it's like, do your research. Not all clinics are the same. Some clinics specialize in different things. I know it's important to take into account where the clinic is, the costs and everything else, but if you have a particular thing, like maybe you have endometriosis or something, make sure that you have a clinic that can do all of the things that go with that, like the reproduction and embryology, immunology and all of that side of things. What I have found is particularly in the time of COVID, which has been very helpful, is that clinics now do a lot of telemedicine, which we didn't do before. It's now normal to do that. So it's easier to perhaps have a consultation in a couple of clinics. You may find that, I know you don't get the same vibe of what it feels like to walk into the clinic, but you do get the feel of the sort of questions that you're being asked and the sort of information that you're needing to put out. Also, find your tribe. It's much easier these days with social media, but it's really important. IVF takes its toll. It's scary, it's emotional, it's really difficult. And having someone that understands what you're going through really, really does help. And also talk about it. One of the things that, has come across with social media is that thankfully these days it is easier to talk about it. When I first started in the early 90s, it really, really was a taboo subject. I mean, no one said anything. You wouldn't have said that you were having treatment. No one knew that you were having treatment. You didn't know anyone who had treatment. Which all of that has changed now, and definitely for the better. And also talk about it with your partner before you start, because men and women do feel differently about it. They respond differently to it. you know, we all look at it differently. So it's always good to just have a chat about it beforehand, just all of the different stages of what might happen and what your expectations are. Diet and weight. I've never worked in a clinic that works on the basis of BMI alone. It's important, but it's also more important just to acknowledge that the body fat does make a difference. Adipose tissue, body fat, is the largest endocrine organ in the body, and it affects our hormones. It gives out hormones. And so if the patient is too light or too heavy, that is going to make a difference. And it's important not to crash diet before treatment, just to be the best version of yourself. That's different for all of us. Now, with regard to diet, research shows a Mediterranean diet is best for IVF. It helps with inflammation, it helps with DNA regulation for egg and sperm development. But whether you're gluten-free, dairy-free is up to you and your individual history. But definitely no sugar, no trans fats, and organic if possible has definitely helps. I do have quite a lot of about this on my blog, allaboutinfertility.com, and on my Instagram and on the various things. I'm going to update all of that when I have a little bit more time over Christmas as well. Sounds obvious, but alcohol, smoking, recreational drugs, no to all of that. Try and reduce alcohol, ideally remove altogether, but one of the things I have always said is that the odd glass of wine here and there, or if you're going to a party, or I mean, obviously not at the moment in COVID, but we get very hung up when we're pre-IVF about what we can and can't do. And I think it's really important to perhaps just live by the 80-20 rule and just try and remember to live a little bit. It's not a good thing to, when we get, I don't know how to explain it really, but we get kind of tied up in it all. And a lot of clinics and things will say, oh, you mustn't do this and you mustn't do that. And yes, it's important, but again, just the odd bit here and there is not going to make a difference. Fluids, our bodies function at their best when they're hydrated. But also, when you start the stimulation injections, the ovarian stimulation, one of the side effects is bloating, and you get a bit dehydrated. And the clinic will ask you at that stage to increase your fluids. And it's a good thing to just get into the habit of it before you start treatment. It doesn't have to be water, just avoid sugary drinks, caffeinated drinks. And remember to drink steadily throughout the day. There is a bit of a thing of, oh, I haven't had my 2 litres of water today, and you drink it all down at once. And when you're in treatment, that's not a good thing to do. So just try and get used to slow and steady. Supplements, individual thing again, check with your doctor. Always check with your doctor before you're having supplements so that they know what you're taking and make sure there's no interactions with anything. But as a general rule, folic acid, vitamin D, again, check your levels. There's no use at all in vitamin D unless you're vitamin D depleted. Omega-3s, coenzyme Q10s, and concentrate on gut health. Environment. Until a few years ago, we actually didn't really know that much about endocrine disrupting chemicals, and we didn't know just how negatively they affect things like the endometrium. They're toxic to egg and sperm. It affects implantation. It's almost impossible to get rid of these chemicals in our daily lives, but we do need to reduce them as much as possible. So really concentrate on washing foods, eat organic if possible, look for environmentally friendly products, all the no cans, no plastics, all of these sorts of things. There's lots of information out there. And when we're drinking water, glass bottles, stainless steel bottles, again, it's back to incremental gains, and it's just about to try and do a little bit of everything. We'll just reduce it down. Exercise, I get asked this a lot. Exercise pre-treatment is absolutely fine. Do whatever you would normally do. But when you start the injections and when you start the ovulation stimulation injection, the ovaries get very big and swollen, and the ovaries sit on stalks. When we jump up and down or whatever, the ovaries can twist on those stalks, and you get something called ovarian torsion, and the blood supply is then cut off to the ovary, and it's quite dangerous. So it is really important to just at that stage, as soon as you start treatment, slow down, just gentle walks, nothing more.
We have had a couple of questions. I don't know if you can hear me, Julie.
Yeah, I can.
Yeah. Two questions that have come in. What are your thoughts on Rebecca Fett's It Starts with the Egg research and book, if you know of that? And there's a follow-up question as well. Also, what are your thoughts of testing for vitamin D and ensuring that serum levels are on or above 50 milligram per L? Sorry, excuse my ignorance about how to say that in NG.
With regard to the book, I personally haven't read it. I've seen lots of people have. I've done lots of research recently into, I was commissioned to do some research end of last year for someone who wanted to know about diet, a particular clinic who wanted to know about diet and things. And it's just coming out more and more. And I think that book was written a little while ago, and it's not years and years ago, but there will be more research that have come out since it. But the principles are definitely there, that diet does make a big difference. We know that more and more now. And even sort of 10 years ago, we didn't really bother that much. You know, it was more a case of what we're doing in the IVF cycle rather than what the patient can do beforehand. Does that make sense?
Yeah.
So I mean, I've read online and things about some of the things that it says in the book. So it's all about when we're trying to improve things for eggs and sperm, it's about the DNA, and it's about how it develops and how you things like that's one of the reasons we advise folic acid for that side of things. So yes, what was the other question?
Just asking about the thoughts for testing for vitamin D and ensuring that serum levels are on or above 40.
Yeah, I would never give advice like that over this sort of medium. But vitamin D levels, yes, test. I would never ever ask someone to take vitamin D supplementation without testing first. They may or may not need it, and they may need a lot more than I would. I take vitamin D daily, but I would, if I was having treatment, I would need more than I normally take. My levels would need to be much higher than they normally are.
Right, so get tested and
get tested, and then see what your doctor wants you to take.
Great, thank you.
So on to medication. Medication errors in IVF are scarily common. Stress and these sorts of things do weird things to our memories, and it's really easy to do the wrong thing. Lots of IVF medications have got all very similar. Cetrotide, Clomid, Clexane, all begin with C. All sound very similar when the nurse is rattling it off to you quickly on the phone. But they all do very, very different jobs. And if you take the wrong one, it will affect things. And if you do something like that, make sure you say straight away, because we can always account for things and we can always change things. But my biggest tip is always get a notebook, write things down, keep a record, because it's good for yourself as well looking back, and it's good for us when we need to know what you've done and what you haven't done. But also don't feel rushed. Sometimes I think in clinics we're very bad at racing through things, and patients are very conscious of time and I don't want to bother anybody. Don't feel that. It's your time. Take your time, ask as many questions as you need, and just write it all down, set timers, and tick off when you've done it, because there are so many times, I do it myself, is that I need to do something or take something, and I don't remember whether I've done it or not, particularly when you're really, really stressed. There are lots of apps out there now. I know lots of clinics use different ones. Use whatever the clinic uses. I know it's great to sort of use an app perhaps, but if your clinic isn't used to using that or doesn't work in that kind of way, that's not going to make life easy for anybody. So just go with the flow of what the clinic does, but ask lots of questions, and that's what the nurses are there for. Ask them lots and lots of questions. They're there for you. They're happy to give you lots and lots of time. And also go through with the nurse what the medication is for, what the side effects are for, what you're expecting to happen. And there are so many different side effects to things: bruising, bloating, irritability, tearfulness, painfulness, tiredness, all of these things. And it's important to know ahead of time that if something's happening, that yes, it's normal, or no, it's not normal, and I need to tell someone.
There's another question coming, Julie. Thank you for that. Do you have any thoughts on the impact that it can have on the body, whether you're prescribed Silogest and progesterone pessaries twice a day versus Lubion and progesterone injections once a day?
Say that again.
It's on the chat wall, and I'm just parroting it off. Do you have any thoughts on the impact on the body, whether it's prescribed to use Cyclogest progesterone pessaries twice a day versus Lubian progesterone injections once per day?
We wouldn't be prescribing either without having done progesterone blood tests to find out what you need.
Okay, so the test would dictate which one, and
you test which you need. And in my experience as well, often it's Lubion plus cyclogest pessaries, and it's very difficult because I'm used to being in a clinic where we do lots of testing. We do testing before and after embryo transfers and things like that. So we test every couple of days, and then we change medication accordingly.
Okay, thank you.
The other thing is sleep. Sleep is getting more and more noticed these days. There have been quite a lot of studies recently on the impact of the quality and quantity of sleep on IVF treatment. There is quite a few studies that do show that lack of sleep does actually have quite a detrimental effect on rates of fertilization and clinical pregnancy rates. And also the things like the coexisting psychological issues, all the difficult things that come with treatment, the anxiety and all that sort of thing, is much, much worse with lack of sleep. So prioritise sleep. Good hygiene is really important. Sleep Council have got some great things. And so actually on your app, I've seen there's some good things on the app. It's difficult because anxiety doesn't help sleep, but try, because we've learned a lot in just the last sort of 4 or 5 years just how much difference sleep makes. And then finally, the most important thing I think is self-care. That none of us can drink from an empty vessel, and quite often the self-care bit is the bit that we do at the end. We do all of the rest of the things for our bodies and then do self-care last. But try and prioritize that. And mindfulness or positive reaffirmations, gratitude diaries, self-care, set boundaries, all of those sorts of things. One of my consultant colleagues from the Independent Nurses Group, Andrea Trago, is very, very good at this. So if you need any advice or anything, have a look at all of her social media. She's very, very good at that side of things. And also consider, for some patients, it's really is worth considering a counselling session with a BICA registered counsellor, who are the British Infertility Counselling Association. As part of practice in this country, all clinics have to have a BICA registered counsellor affiliated to the clinic. And so you could ask your clinic, but also it's easy to look on the website. So that's the patient side of things. Now I'm just going to go over what the clinic can do to help plan your IVF cycle. I have always thought about IVF cycles as kind of a series of hurdles that we have to get through, because we have to go through one to get through to the next. Not like we can jump a stage. It doesn't work that way. And so what I'm going to do is go through what the bits that you can do to ahead of time, which are things like the initial consultation, the monitoring cycle, the ovarian stimulation, the embryo transfer. There are lots of things that we can do to get ready for those to maximize what we can get out of it. The initial consultation. So again, sounds obvious, but patients are individuals, and a one-size-fits-all approach just doesn't work, as well as individualized IVF. Thankfully, individualized IVF is coming more and more. More and more clinics are doing it. And again, sounds obvious, but the clinician needs to spend enough time with the patient to get a full medical history, and also to know the previous IVF history. It's very important when we're doing a cycle. If you've had a cycle before, we need to know exactly how you responded to treatment, how many eggs did you get, how many fertilized, what happened after that. And also, it's good for us to be able to see a full copy of the notes, so not just like a resume from a clinic or something. It's actually part of our regulatory things that we actually we give you a full set of your notes. We might charge a little bit for administration, but ask your clinic. I mean, you might even want them just anyway, just to keep for your own records, but ask your clinic for a full set of notes. And if you go to another clinic, then make sure you take them with you, because it's really important. Clinics also have their own basic tests that they'll ask you to do, and it varies from clinic to clinic. The minimum things will be things like HIV and hepatitis, but other clinics might do other blood tests, and then other things like testing for mycoplasma and things like that. GPs are often quite happy to help at this stage. It might take a little bit longer to get the results, but particularly if you're in a private clinic, it does help with the financial side of things. And also an initial semen test, even if you've had one before, the clinic may want to do one, because often they want their own embryologist to prepare the sample so they can see how it prepares on in the lab. And again, different clinics have different things about things like abstinence beforehand, so do check with your clinic. A monitoring cycle, very important. Not all clinics do it, but I think for those that do, it really does just help to get more information. We start with a monitoring. We start the monitoring cycle with a hormone profile on day 1, 2, or 3 of the cycle. That should include prolactin, FSH, LH, estradiol, and progesterone. Progesterone needs to be very, very low at the beginning of the cycle. If it's not sort of very low, as in 2, 3, then the hormone profile is not correct, and it needs to be repeated when the progesterone is low. At the beginning of our menstrual cycle, it's the drop in the estrogen and the progesterone that starts the period going, and there comes a point where the estrogen and the progesterone are both very, very, very low, estrogen a bit less so, and that's the perfect time to be doing a hormone profile for an IVF cycle. It's a little bit of a different thing whether we're doing it to see what's happening naturally and whether you're going to get naturally pregnant. But with an IVF cycle, it's different. We need to see slightly different things. We then go on to a mid-cycle scan, which for someone with a roughly 28-day cycle would be around about day 10, day 10 to 12. We want to do a scan just before ovulation or around about ovulation. We then check the lining of the womb. We want to see what the ovaries are looking like, count the number of follicles on the ovaries, and look around the area, the adnexa, around that side of things. And we're just looking to see the lining, see how thick it is, and just to see is there anything obvious that's inside the uterus which would cause a problem, like a fibroid, for example. We do an AMH test. We do a post-ovulation test. You'd usually be asked to track your ovulation through and then do a post-ovulation progesterone. Any other investigations, again, depends on your medical history and whether you've had treatment before. Again, we're back to things like reproductive immunology, that side of things. And all of this can be done for someone who has a very irregular cycle or no periods. We can just do it all together at the same time. So you would have your hormone profile, your scan, your AMH all on the same day, and then just go from there.
There's another question that's come in, Julie.
Yeah.
Just putting the financial burden aside for a moment, just looking at what's best, do you have an opinion on NHS, the route and testing versus private? Is it better, worse, or the same? Is the monitoring the same, or is it just because the NHS funding sticks to the basics and bare minimum? Just trying to understand what if the NHS funding for IVF is the same.
Yeah, unfortunately, the NHS funding will affect things because in that side of things, they're stuck a little bit with things like NICE guidelines. So NICE guidelines are just that, they're guidelines, and we can follow them or not follow them to a certain extent. But from a other side of things, no, there's no reason why I certainly wouldn't say to someone, go off and pay for a private test or pay for a private scan or pay for a private anything. If your GP is happy to help you with that, or you're happy you can get it on the NHS, please do so. There's no reason not to. The only thing with that is often the timing. It's the waiting list, it's the waiting for results, and it's just making sure that you do get all of the results. I've had a lot of problems over the years for patients who maybe will have all 5 blood tests done, for example, at the beginning of the cycle, and because they're done, maybe they're not done on the same profile, they might be done, progesterone might be done on a different assay to the other 4 hormones, then the progesterone then goes wandering off somewhere and it's very difficult to get the results back. Just bear all those sorts of things in mind, really, but otherwise there's absolutely no reason to not have things done and not pay for them, whatever.
Okay, I think that answers hopefully the
answer it. Otherwise ask again and I'll fill in whatever I've missed.
Yeah, there's always going to be time at the end if people need to unmute and get further clarification. Please feel free.
Cool. Okay, so on just quickly about AMH, because I see a lot on social media about AMH levels. AMH is a test which is tricky because it it doesn't mean you will or won't get pregnant. It's not a test of that. It's not a predictor of pregnancy. I've just got this little graph. I like this little one. And if you look at a lady, you can see in the middle, a lady of 35, for example. And what this graph shows is centiles. So it shows the 10th, 25th, 50th, and 75th. So if you're 35 and on the 10th centile, which is in the red area, you will produce less eggs on stimulation than someone who's in the 75th centile, which is at the top. But it doesn't mean that the person in the 75th centile has a better chance of pregnancy than the one in the 10th. It just means they're going to make more eggs, statistically. And I just wanted to give that point away because it is important. It's something that patients do worry about. In my experience, they worry a lot. You know, they might get a low AMH level and it's the end. It feels like the end of the world, but it isn't. It just means that as a clinic, we need to take that into account. We need to look at your stimulation protocol, make sure we've got you a short protocol with no downregulation, and you may need to have a higher dose to start with. Back to ovarian stimulation. This little cartoon, I don't know if it comes across properly, has always made me laugh. Heads IUI, tails IVF, then we rock, paper, scissors for those who get to pick the dosage out of the hat, and whoever wins in arm wrestling chooses between polystim and gonal-F. And in the early 90s, when we started, that's exactly what it was like. I mean, we didn't really do blood tests, we did scans every couple of days, hyperstimulation was really common. And things have changed a lot. And one of the reasons for that is because we've learned that we need to collect a lot more information at the beginning. There's quite a lot of research come out in the last couple of years that shows that different clinics and even different doctors within clinics can affect how the chromosomes are within the eggs that we're growing. We can affect the aneuploidy rates, which is the abnormal amount of chromosomes in the eggs, depending on how we do the stimulation. So it's really, stimulation is really important. So we get, obviously we concentrate very much on things like hyperstimulation and that side of things, but it's also as important to know the aneuploidy apparently comes from things like the FSH LH mix. And this is why my big thing is stimulation. I believe very, very strongly that it accounts for at least 70% of a successful IVF cycle, and it needs to be done properly. And so by doing the hormones and by doing the monitoring cycle and by collecting all the information and by looking at your previous cycles and your history and all of these things, then we can collect the information that we need. And my personal checklist is, it's all about optimizing that. So it's optimizing how the eggs grow and the rate of the growth. And so it's about the quality and the quantity. But it's also about how we affect the endometrium by not making the LH rise too quickly, or if the LH rises, the progesterone will rise, which then affects the endometrium. And so we just need to go slowly and carefully. And what we try and do at the beginning of the cycle is to predict the probable ovarian response and then start the stimulation at the correct time, which again is back to making sure we do the progesterone blood test as well as the estrogen and the LH to make sure that the stimulation is starting on the right day. Personally, I use the FSH, the estrogen, and the FSH-LH ratio together with the AMH level and the number of follicles from the scan to then decide which protocol and to finalize the starting dose as well. Starting dose is important, and the first few days and the last few days of stimulation are the most important. And then just the last one, which is embryo transfer. Majority of embryo transfers are...
On that last slide, clarify, did you just say that it's best to do short protocol if you have low AMH? Why is this? What counts as low AMH? Is it 5 or below?
Low AMH, if we go back to the slide, hang on, where am I? Which one am I? AMH, it's important to look at AMH for your age. So you wouldn't say that, I mean, yes, a low AMH for anybody, you would look at, or I would look at a short cycle. Because what we don't want to do, when you downregulate somebody, when you do a long protocol or luteal protocol, so first and foremost, the patient needs to be ovulating, needs to have ovulated, because if you don't ovulate, you don't have a luteal phase. So therefore, immediately, you wouldn't start medication without a luteal phase. That's immediately the wrong thing to do. So assuming you've ovulated, start the medication in the luteal phase, wait for the next period to come, wait for the lining to go and the ovaries to be nice and quiet, and then you start stimulation. But by doing that, you've down-regulated everything, you've damped everything down, and then you've got to get that woof to get it going again, which is fine with someone whose ovaries are going to respond very easily to medication. But with someone with a low AMH, their ovaries won't respond so well. So you do not want to down-regulate and push things down, because the chance of getting things going again is not as easy. So if you use a short protocol, so a short protocol is you start right at the beginning of the cycle, day 2, day 3, day 1 even. And at the beginning of our cycle, we have this kind of what we call a whoosh flare effect that comes with the beginning of the FSH, at the beginning of the cycle. And in the olden days, that's why we used to call it a flare cycle, because we're taking advantage of that whoosh of hormones at the beginning of the cycle. We go with it and we stimulate accordingly. And the low AMH, or a lady who perhaps hasn't responded well before, or who is older, late 30s, early 40s, we often do a short cycle because of that, or in someone who has an FSH which is higher than sort of 9, 10 higher. But again, it's difficult to it's not difficult to explain, that's wrong, but patients are individuals, and I've seen lots of times someone who has a high AMH doesn't necessarily respond to treatment, even though you expect they're going to. And also a really high AMH, sort of 20 and over. Sometimes a patient, and even patients with things like polycystic ovaries who've got really high AMHs, 30s, 40s, they don't actually respond very well to treatment. And it's the main thing with the stimulation is more that you don't just put someone on a dose right at the beginning and then just not check it again, not check the hormones or the scans and things for 3 or 4 days. It's what you do at the beginning. So a low AMH, and the low AMH of 5, yes, is low, and so an AMH of 5, yes, needs to be on a flare protocol. But you also then need to check very carefully. It's unusual to have someone who's got an AMH of 5 who would also have a low FSH, but I have seen it. And I've also seen someone with a low AMH who has an FSH-LH ratio where the LH is high compared to the FSH, and that's another thing. So what I'm trying to get across is I personally would not just take AMH as just a one reading. It's part of a parcel of things that we look at. So it's AMH, it's FSH, it's the FSH-LH ratio, it's the estrogen at the beginning of the cycle, it's how someone might have responded before. And then take all of those things into account just to see what protocol you would put someone on. But as a principle, yes, if you've got a low AMH, then you do a flare protocol, short protocol.
We have got a couple more questions coming in. Do you want to finish the presentation?
I just finish off my last slide, and then we're done with it. So back to embryo transfer. And again, this is something that we can prepare ahead of time for. What we're aiming for with an embryo transfer is a nice, easy transfer with a soft catheter. Catheters come in different strengths, sizes, shapes, whatever. The soft ones we prefer those because the harder the catheter, the more the chance that we can not damage the endometrium, but you can cause bleeding, you can cause the uterus to contract, all of these things. We don't want any of that. We want it to be as simple and easy as possible. And so what we want to do is to get as much information as possible about the lady's individual uterus and the shape and the size and the uterojunction and all of these things. So this bit here, the uterocervical angle, which is, can you see my clicker? No. Can you see my cursor?
No, we can't see your cursor.
Okay. Fine. So on the picture on the left, the yellow bit is a bladder. The red thing is a uterus, and that's an anteverted uterus. It falls forwards, and that's depends on where you read, but that's 1 in 3, 1 in 5 women, so the majority of women. And so when the clinic does an embryo transfer, most clinics will say for these patients, will say fill the bladder up, because you can see as the bladder gets bigger, it straightens out that junction. So where the uterus connects to the cervix, there's quite a kink on that. And it's called the uterocervical angle. the more angulated that is, the harder the embryo transfer is going to be. So what we want is to try and straighten that out, which is easier with an anteverted uterus. Retroverted uterus, it's a little bit more difficult. And so we need to know what that is beforehand. A lot of clinics will do that. They check it again finally at egg collection. We can check that egg collection. One of the other things a lot of clinics we can do is to do what we call a dummy transfer. So we go through the whole process, we use all the same equipment and do a practice run, but without the embryos, just to get a feel for how things are going to be. I personally prefer patients who have had a hysteroscopy if possible, because hysteroscopy is a telescope which looks inside the uterus. So you're actually seeing what this picture shows on the top right hand side. You can see the little white bit. It looks a bit like cotton wool candy floss. That's synetia, and that's like little tiny like adhesion kind of things inside the uterus. It's quite common, but if you're doing hysteroscopy, you can just use the scope and just scrape it away. And a hysteroscopy, we can see the same sort of things when we're trying to get as much information as possible about the uterus. We can have done a detailed ultrasound scan, and that shows a lot. You can see polyps, you can see small fibroids, you can see things on the scan. But with the hysteroscopy, it's like a stage further. You can actually see inside the uterus. You can see on the other side, on the left-hand side, where that little hole is. That's actually where the hole where the fallopian tube comes in. And also the other thing with hysteroscopy is because the scope is going through the cervix, you can make sure that there's no tightening in the cervix. There's no stenosis, there's nothing that's going to make it difficult to get through the cervix to be able to get inside. And also the final thing that we do when we do hysteroscopy is to do a actual measurement of the length of the cavity. Embryos for maximum implantation would go back 15 to 20 centimeters from the fundus. The fundus is, you can see on the green little thing, the fundus is the top of the inside of the womb. So what we do is we take a measurement from the fundus to the outside of the cervix, and textbook average is 8 centimeters. So for that particular patient, we would put the embryos back in at 6 to 6.5 centimeters. But everyone's different. We're all different. I've had a hysteroscopy. I know that my uterus is tiny. So if I was having an embryo transfer, my embryos would go back in at a completely different place than someone else. And it's important things to know. And also, if we've got fibroids, fibroids on the inside of the uterus we would need to get rid of. But fibroids on the outside of the uterus don't need to be removed pre-treatment. But what they do is they affect the cavity. So I always remember a few years ago, I had a lady she had a hysteroscopy. Uterus was 7 centimeters and she went off to have a baby. She came back a few years later. We did another hysteroscopy. Uterus was 9 centimeters. And I remember her saying to me afterwards, well, what happened? Did you make a mistake? And no, what happened was she actually has fibroids. And so what the fibroid has done is it's lengthened out the cavity. It affects the length of the shape and the length of the uterus. And therefore we needed to know that so that we would know where to put the embryos back in a different place this time. So that's me done. Thank you very much for listening. Hope that all made sense. A bit waffly at times. Please let me know if you want me to go through anything again, and any questions for me.
Yeah, that was very clear. Thank you so much. There are some questions that have come in. Perhaps you can stop sharing your screen so we can see you, and I'll put the questions to you. My chat function. Here we go. So someone was asking, why would someone recommend going on the pill first? Would you go on the pill if you were doing a long or short protocol?
Going on the pill is sometimes called estrogen priming, and there's different reasons for going on the pill. For some clinics, they go on the pill to regulate the cycle, to know when to start if we need to do that. Some clinics also, not every clinic works 7 days a week, 365 days a year, and so they have to batch patients. There's nothing wrong in that. We used to do it all the time many years ago, and some clinics will do that. Some clinics do put people on the pill beforehand because they believe that's the best thing to do.
Okay.
Different doctors, different beliefs, different knowledges, different experiences. Lots of clinics do lots and lots of things in different ways. Ask your clinic why, because you say it could be because it's the best thing for you. It could be because it's the best thing for the clinic. It just depends what it is.
Okay. And then someone was asking, is it important to let the body heal properly between egg extraction and embryo transfer, or does it not matter? She's saying the literature is rather mixed on this point.
I don't understand as in heal properly, because for most fresh cycles, you would do an egg collection and then do an embryo transfer 2 to 5 days later. That's normal.
2 to 5 days is normal.
Yeah.
No,
Yeah. So as a general rule, if you're going to have a fresh cycle, the egg collection, we call the egg collection is day 0, as it were. And then day 1, fertilization. Day 2 is the first day that we can put embryos back. So most embryos would go back day 2 or day 3, or they would go back on day 5, which are blastocysts. And again, it's clinic preference as to what they do, but it's also depending on the number of embryos. So if you had a few eggs, you ended up with just a couple of embryos, then there's not necessarily any benefit for waiting other than to find out whether those embryos are going to develop on. But if you had 5 or 6 embryos, then you would carry on to blastocyst, because then you would see how they developed on. And there might be a little bit of fallout, and not all may make it to blastocyst. So you would then be able to choose the ones that seemed more able to implant.
Okay. And is it important the thickness of the endometrium at embryo transfer stage? I read that literature where it said 7 millimeters is sufficient, and others saying it needs to be 20.
20? No, 20 is huge.
Clarification on that.
No, you don't. No. There is different literature, and literature has come. There has been more literature actually came out. There was a study came out, I think, earlier this year, which was saying things like actually anything sort of 5 and above implantation can happen. But what you would like to see is, I mean, ideally in a perfect world, yes, sort of like 7, 8 and above. My average is, from what I've seen, is between 8 and sort of 11 at that stage.
Okay. And slightly more personalised on, I think it's the last question that I've got for the moment, unless anyone wishes to unmute and there'll be time and ask their question. There's time for that. What makes a clinic choose to monitor HCG levels from the moment a positive pregnancy test is reported? And given this lady has endometriosis and it's via IVF and she's 39, it would have seemed like something to do. Private clinics do that. Is that something that should be done? Monitoring.
Again, this is back to my experience. I've always monitored HCG levels from the first time, always, every second day, particularly with things like endometriosis. Yes, you want to see it rising. You want to see a nice steady increase. It's difficult from a patient point of view. I've always thought one of the bad things that we do to patients when we do that is we make you so anxious, because if we're doing a blood test every second day and textbook says it's supposed to double every second day and then it doesn't, and what's happening and all of it, but in reality it doesn't work that way. It comes in fits and starts. You know, you might get a big jump one day and not much happening the next, and then it jumps again. It's more to see a nice sequential gain in the beta HCG. But also, again, my experience is also, yes, we test beta HCG, but we also test progesterone, because it's one of the signs of seeing, is the embryo implanting properly? Do we need to change medication? And that's one of the reasons that we test HCG, is yes, to see what's happening, but it's also to see, do we need to change anything, particularly in patients with inflammatory disorders, with things like endometriosis. Yes.
Okay, I hope that answers their question. But otherwise, I did post earlier the website allaboutinfertility.com, which will give you access to Julie, and also via our app, you can link it up with her via the resident expert section. Then we have had one last question come in. If you have low progesterone, is Lubion the only option?
No, not necessarily. I mean, it's cyclogest, and there are other things on the market as well.
Okay. All right, so if there's not any final questions coming in, just to say thank you so much for breaking that down for us, Julie, really helpful, and there was a lot of questions and engagement, so obviously really helpful for people. Thank you very much.
You're welcome, hope it helps.
Okay, thanks everyone. You can always rewatch this on the Fertility Circle app under events and playbacks, and reach out directly to Julie via the app. So I hope this helped, and wish you the best for your day. Thank you.
Thank you.